Good morning, everyone. So today we'll be discussing about prenatal diagnosis of chromosomal abnormalities. So what is the purpose of prenatal diagnosis? So in some cases, we want to reassure the couple if everything is normal. If anything is abnormal, we can offer choice of termination. In some cases, such as congenital diaphragmatic hernia, where surgical intervention is available, we need to rule out major chromosomal abnormalities before undergoing any surgical intervention. Sometimes if the baby has some major malformation, we may avoid surgical like cesarean section at the time of birth. And sometimes it is essential for psychological counseling so that the family is prepared. So there are various types of malformations, and on an average, they are seen in around 3% of pregnancies, and most commonly cardiac malformations, CNS malformations, skeletal and urogenital malformations are seen. In 50% of cases, we can identify the cause due to recent advances such as microarray and now next generation sequencing. So for fetal malformation, we need a multidisciplinary care by an obstetrician, fetal medicine specialist, geneticist, perinatal pathologist, and genetic counselors. So the first investigation is karyotype. It can detect major chromosomal abnormalities such as aneuploidy, translocations, deletions, or duplications that are more than 5 to 10 MB. Fetal karyotyping can be done by chorionic villi taken at 10 to 12 weeks or amniotic fluid taken after 16. And reporting time is around 14 days. The most common chromosomal abnormalities are trisomy 21, followed by trisomy 18, then structural rearrangement and trisomy 13, and monosomy X, and then triploidy. So these all abnormalities we have commonly seen in our day-to-day practice. So it has been seen that abnormal karyotype is seen in around 16 to 30% of cases which have structural malformation identified on ultrasound. And if there are more malformations such as multi-system involvement, the risk of chromosomal abnormality increases to 30%. If there is no abnormality on ultrasound, then also abnormal karyotype is seen in around 5% of cases, such as those cases referred for positive screening test or advanced maternal age. So the malformations which are greater likelihood of chromosomal abnormalities include cystic hygroma, the non-immune hydrops fetalis, increased NT, holoprosencephaly, structural heart defect, duodenal atresia, omphalocele, and ventriculomegaly. So this is a case, as you can see that there is increased nuchal fold thickness, short femur, there is echogenic bowel, and also there was single umbilical artery. Then on postnatal examination, you can see that there is upslanting eyes and there is a sandal gap. So what is the diagnosis? Down syndrome. Okay. So in this case, we had done MLP, and here you can see that these dots are above the rest of the dots. So this is suggestive of trisomy 21. On karyotype also, we see that there are 3 chromosome 21, which is suggestive of trisomy 21. So in this case, we can do all, we will reach to the diagnosis by either of the investigation, either by MLPA or by QF-PCR or FISH or karyotype. Okay. So for major chromosomal abnormalities, any of these methods will be good. Then next.
Why did you particularly choose MLPA?
Because the family had not paid for the test, they had paid for the karyotype, and we did the MLP free of cost.
Okay.
It is fast. Karyotype will take time.
Yeah, fish.
Maybe we had done it earlier.
Fish we had not. We are not doing nowadays, and QF-PCR also, like MLPA is like we. If we are doing any free testing, we more preferably do MLPA due to financial reasons.
MLPA is the cheapest test out of all.
No, not like that. But in our lab, we are doing like that because we have multiple probes for that. So in QF-PCR,
What's the advantage? Like if there is duodenal atresia, I forgot. I didn't see what was there.
soft markers.
Soft marker. So if we are very sure that we are only for duodenal atresia and 30% are trisomy 21, then we may do PCR, But sometimes I personally prefer NFPA because if somebody wants quick result, then look at all chromosomes. So there are two options: karyotype, which will take longer time; microarray, which also takes little longer time because first we do qPCR and the cost is involved. So to look at all chromosome by molecular cytogenetics technique, then NLPA using subtelomeric probes is an advantage. Because not only because we are not sure whether there will be only trisomy 20 and 18, 21 or any other chromosomal imbalance can be there. And if there is a double segment imbalance, then we also have the possibility of high risk of recurrence. So that is the compromise of cost and using molecular cytogenetic techniques, which will have high resolution and also quick reporting time. But only the disadvantage is that qPCR, the chromosome 21, there will be many probes, at least 5. And in case of subtelomeric MLPA, it's only ends of the chromosomes, end of QOM. In case of acrocentric chromosomes, it's a near centromere part of the QOM. It's not really QOM.
Moreover, MLPA do not look for and actually take care. Like for POC, we will always do qPCR class, rule out maternal contamination and the different thing for all. Because trisomy 16 is the most common. No?
Trisomy
16 is the most common. We often get, but we need to rule out maternal contamination. MLPA does not rule out maternal.
So coming to next case, so this was a 4th gravida female, came at 20 weeks and quadruple test was high risk for trisomy 21, ultrasound was normal and qPCR was also normal for common aneuploidies. So here you can see that there are multiple chromosomes. So what is this? Triploidy. But here you can see that there is mosaicism for triploid cell line. Okay. So 33, we have counted around 65 cells, and out of these 65, 33 have 46 chromosomes and 32 have 69. Okay. So this particular patient had mosaicism for triploidy. Okay. So now what to counsel? qPCR will not be able to detect triploidy. MLPA will also be not able to detect triploidy. So here comes the advantage of doing karyotyping. Triple X it will detect, but here triploidy is okay.
That is what
So now we have to do the literature review. So this particular thing is known as mixoploidy, when there are 2 cell lines in a single individual with different ploidies. So in this case, there can be variable fetal outcome. IUGR can be there can be intrauterine death, stillbirth, or there can be early neonatal death. But in some cases, it has been seen that the postnatal outcome is completely normal. And when karyotype is done from peripheral blood, then it is normal. So next we can advise karyotyping from fetal cord blood. So if that is normal, then also we will not be sure about the outcome of the baby, because some tissues can have triploid cell line like skin and other tissues. So in this case, we have to counsel that the outcome can be variable and we cannot reliably predict the outcome on the basis of our prenatal investigations. Microarray can detect triploidy, but since this is a mosaic, so there may be some issues related to mosaicism.
Coming for the next conception, not the constant issue repeats.
So in general, these type of cases do not recur. But if the patient wants to be doubly sure, then we can offer prenatal diagnosis. But the risk of recurrence is very low. By amniocentesis.
We advise termination of pregnancy.
We cannot advise termination in any case, whether the baby is having a diagnosed chromosome 21 abnormality, we have to counsel regarding the outcome, and then the family needs to decide whatever they need to done. Okay, so in this case, we know that the outcome is variable. So the family may opt to do further testing by fetal cord blood, and if fetal cord blood karyotyping is normal, then they may wish to continue the pregnancy. So it depends on the family, for the wishes of the family, what they want to do. Okay, so we have to counsel the prognosis only. We cannot decide the further course.
Then why amnio have, why not otherwise fetal in the next pregnancy? But
Because for these type of triploidy, sometimes it is seen that the placenta is triploid and the fetus is completely normal. So in that case, CVS will lead to false positive results.
And in general, if the risk of recurrence is 1% or less, then we would always prefer amniocentesis because the risk of spontaneous abortion following amniocentesis is there. But more important is there are very little chances of maternal cell contamination, and the quality of karyotypes is very good. So if you take direct away that DNA-based testing or molecular cytogenetics, then everything or karyotypes. So quality of chromosomes is also good. So all things technically are better, and the risk of abortion is less. So if the risk of the disorder is not very high, then one would wait for a 60 weeks. That the delay is not major important. But if risk is high, like 25%, we would like to have early diagnosis as early as
2022. Then, ma'am, yes, ma'am. Then we are sure that the baby is actually having this type of cell line, and the prognosis is likely to be poor. Like in current scenario, we can take permission for MTP after 24 weeks also. So if there is a particular indication we are not able to provide early prenatal, then we can go for a late termination also. And if you are taking blood at 22 weeks, try to do karyotyping early, then the result can be provided in 14 days. Then coming after karyotype, we can offer rapid aneuploidy test. So there are three types of tests: FISH, MLPA, and QF-PCR. So they are rapid tests for common aneuploidies, trisomy 13, 18, 21, and also for sex chromosomal abnormalities. FISH and MLPA can also detect common microdeletions if we are using the probe set for common microdeletion. The reporting time is around 2 to 3 days because cell culture is not required. We can directly take the cells from the amniotic fluid or CVS sample. Advantage of QF-PCR is that it can detect maternal contamination also. So another case in this baby, in antenatal USG, truncus arteriosus was detected, and after birth, we see that there is a facial dysmorphism. So in this, what do we suspect? So in this case, we had done MLPA for common microdeletion, and here you can see that on 22q1121 region there is a deletion. Okay, so this is a case of DiGeorge syndrome. Now, this case at 14 weeks, the fetus had cystic hygroma and left diaphragmatic hernia, which was also confirmed on postnatal examination, and there is history of spontaneous first trimester abortion. So, which investigation would you like to do? Yes. So, we can do straight away microarray, or we can do QF-PCR also, because cystic hygroma may be associated with trisomy 13, 18, 21. Okay. Or we can do MLPA. Fish can also be done for 13, 18, and 21. Yes. Yes. So in this case, we are not very sure that the fetus will be having any common aneuploidy. Okay. So the fetus can have other chromosomal malformations also. So the best test at this time is to offer microarray. Okay. But if the family is not affording, we can do MLPA, as it will detect the imbalances which are present at the subtelomeric region. So in this case, we had done MLPA and karyotype. So on karyotype, you can see that there are 47 chromosomes and this one is extra chromosome. Okay, so this is a marker chromosome, but we don't know what is the origin of this marker chromosome. Okay. On MLPA, here you can see that on chromosome 11, there is a blue dot, which is above the rest of the dots. And on chromosome 22 also, there is duplication. So there is duplication on both chromosome 11 and 22. So we know that chromosome 11 and 22 duplication is seen in a condition known as Emanuel syndrome, in which the marker chromosome is composed of part of 11th chromosome and part of 22nd chromosome. Okay. So this particular chromosome is composed of 11 and 22 and known as derivative 22 chromosome. Now we had done microarray also.
The previous like it is written plus derivatives, but it is unbalanced concentration.
So regarding nomenclature, first we have to write the total number of chromosomes, that is 47. Okay. Then as such on karyotype, we don't know what is the composition of this marker chromosome, but since we had done MLPA also, we know that this chromosome is composed of 11 and 22 and the centromere is from chromosome 22. So we have named this as derivative 22 and this chromosome has arisen from translocation between 11 and 22 and these are the breakpoints which are present on 11 and 22. Okay.
All these things we discovered in MLPA.
On MLPA, we discovered that there is gain, means extra material on chromosome 11 and 22 duplication. So we don't know the size of duplication on MLPA, not on karyotype also. So for the size of chromosome and the exact location where the duplication is situated, we had done microarray also. And in this, you can see that this is a region on 11th chromosome that is duplicated, and this is a region on 22 chromosome that is duplicated. So the gain on 11th chromosome was 18 MB, and on 22 chromosome, the gain was around 4 MB. Okay. Then in this case, would you like to do the karyotype of parents? Okay. So whenever there is an imbalance chromosomal rearrangement, we would like to do karyotype of parents to know whether it is inherited or it is de novo. So in this case, we did the karyotype of parents and mother was found to be carrier of translocation between 11 and 22 chromosomes. So next case, this lady was referred at 23 weeks with high risk for trisomy 21. So here you can see the skull shaped is strawberry shaped skull is there. Then there is retrognathia, polyhydramnios was also there along with fetal ascites. So what is the probable diagnosis? Trisomy 18. So when there is abnormality in head shape, we usually suspect that there is trisomy 18. So then we did the rapid test that was normal. We did karyotype. So this karyotype also looks as normal. But since there was an ultrasound abnormality, we need to do further testing. Okay. So as in all cases, we first did MLPA. So on MLPA here, you can see that there was gain at chromosome 17 and loss at chromosome 9. Okay. So why this gain and loss were not visible on karyotype? Maybe the size is less than 5 MB, that is below the resolution of karyotype. So in that case, karyotype will be normal in spite of imbalance. Okay. Then we did microarray, but on microarray we saw that the gain is 16 MB and the loss is 17 MB. Okay. So the size is almost similar. There may be some subtle differences in the banding pattern. Okay. But these banding patterns, the change may be missed when we are doing karyotyping because it is operator dependent also, and sometimes the banding pattern may be similar, somewhat similar. So in this case, the abnormality was not identified on karyotyping, it was identified on further investigations. So in cases with ultrasound abnormalities, we need to do microarray as it will detect the subtle chromosomal abnormalities which are not picked up by karyotype. So this is a postnatal phenotype of baby. So she has developmental delay along with facial dysmorphism. So now coming to chromosomal microarray, it is now recommended as a first tier test by ACOG because it can detect some microscopic abnormalities. Reporting time is around 7 to 10 days. So in cases of normal karyotype, the increase in detection rate is up to 6%. In case of multiple malformations, the yield is increased in about 13% of cases. So in prenatal microarray, we can do in cases with the structural malformations, if we identify any abnormality on karyotype such as marker chromosome or apparently balanced chromosomal rearrangement, there can be multiple soft markers, positive serum screen, and advanced maternal age, or if one of the parent is a carrier of balanced translocation. If there is previous pregnancy with some microdeletion duplication, if the parents are anxious and they want to do all the investigations, then also in every case in which we are doing invasive testing, we should offer microarray. So the most common copy number variations we see are 22q 11.2 microdeletion as well as duplication. Then 17q12 microdeletion is seen in genitourinary defects and 16p 11.2 duplication in GI defects. So the softwares that are used to interpret the microarray results, so we can look in PubMed if there is any specific abnormality. We can look in OMIM, and there is a database known as Decipher. It contains the chromosomal imbalances that have been already reported in diseased individuals. Then CleanVar, it is also a similar database like Decipher. In DGB, the chromosomal variations that are observed in normal population are catalogued. ISCA is now not routinely used. And then we have a database of genotype and phenotype. So this was a study done in our department where the diagnostic yield of microarray in cases referred for high risk for aneuploidy was 5%, and in cases with major structural malformation, it was around 8%. Similar study has also been done in Gangaram, where the additional yield was 3.8%. So coming to types of microarray, so there can be comparative genomic hybridization where we compare the result of the patient to a control sample. In SNP array, we compare the result of the patient with a set of reference, with a set of established controls. In SNP array, there are two types of probes. There are copy number probes and there are SNP probes. So are all microarrays same? No. So there can be some targeted microarrays also. So these are developed for specific regions of the genome where we know that copy number variation is reported to be pathogenic or likely pathogenic. And there are whole genome microarrays. So they cover the entire genome and there are multiple probes for each region. So for an example, we have Cytoscan 750K. So this particular kit probe, the number of probes in this particular chip are, there are 7,50,000 SNP probes along with 1.9 million copy number probes. There are some other platforms such as 44K, 180K, 400K, 850K, and 1 million K. So according to the type of array, the number of probes will differ. So the functional resolution and the sensitivity of array will depend on the type of probes, the probe spacing, and what are the number of probes that are used to identify a copy number variant. And what is the size filter that we are using during the data analysis. Suppose we are reducing the filter from 200 to 100, then we will identify more copy number variations. Okay. So normally the cutoff that is recommended is 200 kb for losses and 400 kb for gains. Some societies have recommended that for prenatal microarrays, we should increase the cutoff. So for gain, they recommend it should be more than 1 MB, and for loss, it should be more than 400 kb. But since we are not having any guidelines for our country, we are following the same cutoff for prenatal and postnatal microarrays. Okay. That is 400 kb for gain and 200 kb for loss. So there has been various studies, and this is a particular study by Wang et al. Published in Prenatal Diagnosis. So they have compared the yield of different platforms. So if we are using the 2.6 million probes versus the 44K, so the yield increases by 23%, but the yield for pathogenic and likely pathogenic CNVs increases by around 6% only. So the rest are variant of uncertain significance. So if we are increasing the density of probes or we are decreasing the size cutoff, then we will end up with more variant of uncertain significance. So uses of microarray we have already studied. It can detect DNA copy number gains and loss across the genome. So the advantage of SNP array is that it can detect loss of heterozygosity. It can detect homodisomic uniparental disomy. It can detect mosaicism to the range of 30 to 70%. Okay. It can detect maternal cell contamination also and polyploidy also. The limitations of microarray include it cannot detect balanced rearrangements. It will not detect the imbalance which is present in the regions that are not covered by that particular microarray kit. Single nucleotide variations will not be picked up by microarray. For that, we require to do Sanger sequencing or NGS. Polyploidy changes can be detected only by SNP microarray, not by the copy number microarray. Low level mosaicism that is less than 30% will not be picked up by SNP array also. Imprinting defects will not be detected. Likewise, heterodisomy will not be detected by microarray. And sometimes we may not be able to interpret the copy number variant that is detected. And there may be issues in interpretation of variant of uncertain significance. So there may be uncertainties related to CNVs that have incomplete penetrance, that have variable expression. Sometimes there may be issues regarding the gene disease correlation. We don't know the prenatal phenotype of some copy number variations, so there may be issues in counseling in that. Sometimes we may come across some incidental findings and some secondary findings. So coming to next case, in this, the dual marker was high risk for trisomy 21, ultrasound was completely normal, and QF-PCR was also normal. So in this, what is there in karyotype? Marker chromosome. Okay, so now what we need to do? CMA. Okay. So we did microarray in this case. So microarray, what can you see? So this is the result page. In this, you can see the various copy number variations. So here there is a icon for filter. From this, we can apply the various size filters. So we need to see gains more than 400 kb, loss more than 200 kb. So after applying these filter, we have 4 copy number variations. Okay. If we decrease the size filter, then the copy number variations will increase. Okay. So now after applying 400 and 200 kb filter, we have 4 variations. So we need to look at each of these copy number variations, whether they are pathogenic or VUS or benign. Okay. So this particular copy number variation, that is gain at 9p, this is shown here also. So this is chromosome 9. So as you can see that this is a centromere and there is a blue line over here. Okay. So blue line in majority of databases represents gain. Okay. So here we interpret that there is a gain involving the Q arm of chromosome 9. Okay. So this marker chromosome was actually this part of chromosome 9 and the size of this duplication is around 38 MB. So it is a large duplication, so likely to be pathogenic. So what other investigation could have picked this duplication? MLPA. So had it been picked up by QF-PCR? No, because QF-PCR is a targeted test limited to 13, 18, 21 and X and Y chromosomes. Okay. So if we had done MLPA in this case, then also we would have picked this abnormality. But in MLPA, we will not be able to determine the size of duplication. So the size of duplication will be determined only by microarray. But since we already have a marker chromosome, we know that the abnormality is significant. Okay. So coming to next case, this is a 23 weeks lady. Then ultrasound showed tetralogy of phallat and QF-PCR was normal. So what will be the next? What will be the provisional diagnosis? George. Okay. So next test. Yes, we can do fish for 22q since there is a tetralogy of phallat. So we suspect DeGeorge. We can do fish for DeGeorge. And when you are ordering any test like fish, you should mention that what is the indication. Okay, suppose you just say fish, they may do fish for common aneuploidies. So that will not detect DeGeorge syndrome. You have to say that we need to do fish for 20. Okay. So now suppose we had done fish in this case, and that is normal for DeGeorge syndrome. Now next investigation, microarray. Okay. So in this case, we had done microarray. So here you can see that there are 3 copy number variations after applying filter, and out of these 3, this one is significant, and there is a large duplication on chromosome 22q13 region. Okay. So now, can it be detected on MLPA? Yes. Okay. Because this region involves subtelomere, so it might have been picked up by MLPA also. So that is why MLPA subtelomeric we are doing in every prenatal case in which we are not able to do microarray. Okay. So in this case, we suspected DeGeorge, but that was not there. Okay. So for undiagnosed, like clinically undiagnosable, microarray is the preferable test.
Phone number. Phone login.
That I want to say that there is no list of conditions. Okay. So first we have to assess clinically. So if we are suspecting trisomy 21, we will first look for that. So if trisomy 21 is there, fine. Okay. But if what we are not suspecting on clinical basis, then we need to do either microarray or as a subsidiary test, we can do MLPA because it will look for the imbalances on the subtelomeric regions. Okay. No, ma'am. There is no condition according to the phenotype.
बेगम,
Okay.
उधर उजेर साहब है क्या? नहीं है?
One P minus and one is 9 wala jo ek
Valid username it is. Enter it.
point. They do not have any ultrasonographically detectable abnormalities. So we cannot suspect them in prenatal
Already
samples.
taken.
If you cannot do microarray, or if you want a rapid test to look at all chromosomes, like trisomy of 16, trisomy of anything, then the subtelomeric approach set has an advantage. There are 2 advantages. Any small deletion duplication involving
Mobile
ends
number
of the
is
chromosome picked up, which may not be picked up on karyotype because it is very small, and the terminal bands are very light in color. So even a small band here is to be gone to other chromosome and duplicated, and this is shifted here, you may not find out. So because being very, it can detect very small
487393.
in the chromosomes, it has advantage. Secondly, so naturally, if there is a 2-segment arrangement, some of them may be inherited from the parents.
Huh?
And if you want to look at terminating, and if you want to find out whether it is likely to recover, so They are more interested in not only trisomy 21 or trisomy 16, but in those chromosomal arrangements which are double segment. And those will be picked up. And third thing is that if there is a trisomy of chromosome 14, 15, 17, which are not there in PCR, those also will be picked up because we have a probe at the ends of those chromosomes. So, though we do not have like microarray probes all over the chromosome, but if there is a trisomy of say 15 P and 15 Q, it means that probably the whole chromosome 15 is duplicated. So it can look at once it is a rapid test as compared to chromosomes, it will look at all chromosomes, though they are only ends, but it can detect microdeletion duplications involved in trisomy of those chromosomes in a rapid way. And then if you have microarray, all these things are there and many more advantages. But if microarray being positive, you cannot do that, then this is it will not fail. Okay. So these are the advantages, and then you can accordingly decide.
And literally also we can let them know MLT.
No.
See, PCR में अगर 13, 21, 18 सबका trisomy हो रहा है, so that is an indication.
Okay. So here the duplication was involving 22q13 region detected on microarray, and the size of duplication is 10 MB. So it might be picked up by karyotype also.
And like this, there is a possibility that microarray also comes out of the office. Can we label it out?
Yes, there are various single gene conditions also that are associated with TOF. So the message is that first we have to make a clinical diagnosis, but if our investigation is not detecting the particular abnormality, then we should look for other abnormalities also. Yes.
And we should go into what?
Microarray. If microarray is normal, then considering monogenic disorders, if there is any abnormality that can be seen in monogenic disorders, then NGS can be done.
We have to decide one test after
One,
if your PCR is normal,
if only one test, then microarray.
because we cannot, once you have done PCR, then go to MLPA.
No,
Then order
that we don't need to do. But if the family is not affording, they don't want to do microarray, then we can do MLPA. So another case, this is a second gravid female. So they had come because their previous child was having trisomy 21. So at 16 weeks, the ultrasound was normal and they opted for karyotype and CMA. Fetal karyotype was also normal. But in microarray, there is a deletion on chromosome 17. So here you can see this is a red line. So red indicates deletion, blue indicates duplication. So this is a small deletion. Here you can see this is a small deletion. So the size of deletion is around 1 MB. So now we have to do literature review whether this deletion is pathogenic or benign. So first we suspect according to size. So the size is around 1.4 MB. So likely to be pathogenic, but still we need to look the literature. So first we look at DGV, that is genomic variants in human genome, that is normal population. So here there is no entry. So this particular region, it is showing the area that is involved in our patient. So there is no entry in this region, means this particular duplication is not present in normal, not reported in DGV. Coming to OMIM, so here we see an entry that is 17q12 deletion syndrome. Okay. Then we see the phenotype. So this particular abnormality can have genital tract abnormalities. So there can be renal cyst, multicystic dysplastic kidney. There can be genital malformations also. In other cases, there can be neurological abnormalities such as autism and intellectual disability. And it has been seen that in around 30% of cases, it is inherited from one of the normal parents. So there is a intrafamilial variability. Suppose parents are normal because they have not come with any issue, and this fetus is also normal according to ultrasound, but on microarray we are detecting a copy number variation that also has variable clinical features. In some cases it will be normal, and in some cases it may be associated with intellectual disability or some renal problems. So what should we counsel this family? So we have to counsel that this is the scenario. These all features can be present. We have detected a microdeletion, that is an incidental finding. So usually we do a repeat ultrasound when the patient comes for taking report. So on repeat ultrasound, after 3 weeks, we detected a right multicystic kidney. So now we know that the baby actually has some renal manifestations, and then the counseling became easy, and the parents also understood that the baby is affected with a microdeletion syndrome. So in some cases, only detecting a microdeletion will not be able to predict the postnatal phenotype, and in this case, it will be challenging to counsel the parents regarding the implications. So in this case, the review ultrasound somewhat cleared the picture regarding the fetal prognosis. So will you like to do the microarray of parents in these cases? In this case? We should do. Why? Because this particular deletion, as reported in literature, has variable phenotype. So it can be seen in cases where there is no symptoms, or simply the one of the parent may have diabetes. So another name for this condition is renal system diabetes syndrome. So we need to do ultrasound of the parents to look for any renal cysts that may be asymptomatic till now, and sugar levels. So one of the parent may be a carrier for this particular duplication and may be entirely asymptomatic. So regarding prenatal diagnosis in next pregnancy, so if one of the parents is a carrier of this particular microdeletion, then the risk will be 50%. And if the parents are normal, this particular deletion is de novo in the fetus, then the risk of recurrence will be less than 1%.
Regarding you ask why microarray not other method. So for every area, you may not have immediately available rows and so on. So easier way is to directly do microarray. The recurrence rates.
So if one of the parent is carrier for this microdeletion, then the risk of recurrence will be 50%. Okay. And if it is de novo, means not present in the parent, only in the fetus, then the risk will be less than 1%. So in any case, we need to do prenatal in next pregnancy, but the risk of recurrence will vary according to the carrier status of the parents. Yes. Yes.
Even if deletion is present and ultrasound is normal, we can continue.
Pardon? If ultrasound is normal.
This baby has. There are many abnormalities in this syndrome, like intellectual disability and uterine abnormalities, which may not be detected. So not that everybody has intellectual disability, but some of them do have. For this particular syndrome, lot of information is known because many patients are reported. So we look at when we do parents of microarray, if you identify a small deletion, 1 MB, and there is no information about in the literature, then we could go in the parents and think that if it is de novo, it is likely to be pathogenic. And if it is present in the parents, then and parents are normal, then it is likely not associated with any phenotypic abnormalities. But for this type of microdeletions, where already lot of information is known, and two important points of the information are that many of them are de novo and some of them are inherited from normal parent. So by doing parents, they are not going to add the information about outcome. It's not that parents have the deletion and are normal, So child will be normal, fetus will be normal. We know this in a significant number of cases, the individual may have abnormality. And ultrasonographically detectable no abnormality, still some of them may have intellectual disability. So decision about termination will depend on all this information. Even if there are no cysts in the kidney, still there is a significant possibility that maturity onset diabetes of all young, which is treatable. But uterine abnormalities, which also may not be very issue. But significant intellectual disability and cystic changes, which later on some of them will lead to chronic renal disease. So uncertain, there is lot of uncertainty, but information is available, and still that is a challenge for counseling.
The parents' choice is
No, ma'am, this is a microdeletion syndrome. So for microdeletion syndrome, usually one allele is affected. So that is the point and the message. If everything is normal, then also microarray can detect significant abnormalities in 1% of cases, 1 to 2%. So now it's a recommendation that we should offer microarray in every case we are doing prenatal testing due to any indication. So in previous case also, ultrasound.
Making an important point. So can you repeat? This is the important message for
So
everybody.
in this case, like the prenatal was done due to previous child with trisomy 21, but we detected a significant microdeletion. So it has been seen that a significant microdeletion can be detected in around 1% of cases with no ultrasound abnormalities. So now it has come in the recommendations also that we should offer microarray in every case we are doing invasive testing. We are doing invasive testing. We are taking sample. We should offer microarray. मैम ये का जो कंसेप्ट है वो मोनोजेनिक डिसऑर्डर्स में ही अप्लाई होगा ऑटोसोमल डोमिनेंट वन एलील रेसिस्टेड बोथ एलील इसमें नहीं होता है क्रोमोसोमल डिसऑर्डर्स में नहीं होता मींस क्रोमोसोमल Yes. So this fetus, now we see that there are some renal abnormalities, but intellectual function we cannot predict. So the family needs to decide whether they want to continue or.
So now that is the message is that whenever we are going at the invasive test, we will do irrespective of whether it is
What we are like if we so trisomy 21, then we'll go PCR and the report is normal. Now we have the sample remaining. We can tell the parents, we can look at other abnormalities which are also associated with the significant poor outcome of neurodevelopmental disorder. So we will offer that to all patients, and that has come after many years of experience of microarray prenatal sample. But same thing we are not at present doing, that we offer NGS also for everybody in amniotic fluid. That we are not doing. But microarray is because we know if ultrasound is normal, still 1% of them have pathogenic copy number variations. So all those patients which we see as Smith-Magenis syndrome, Williams syndrome, and so on, those are microdeletion syndromes we see in children, and those can be picked up by prenatal microarray. So we will not do for everybody amniocentesis, but if we are done amniocentesis for trisomy 21 or for some monogenic condition, and then that abnormality is not there, then we can offer them and process the remaining sample for microarray. Soft markers should be of a microarray, for example.
Yes, in every case.
Then the guidelines say there's risk of trisomy 21. But even if whatever the risk is, the magnitude of 5%, 10%, and then if that is not there, then we have the remaining sample, and now it does not have anything to the economic focus. But just because you have sample which is collected from the invasive way, and then you can offer, we can look at many other things which may be associated with intellectual disability. Those are ultrasound is normal. One percent में मतलब सैंपल लेने के लिए कोई और रीजन है, बट इन्वेसिव वैसे इतना लिया हुआ सैंपल है, and you can look at one मतलब कंपेरेबल कर सकते हैं, तो फिर आपको ऑफर करना चाहिए।
काउंसलिंग करते हैं पेशेंट की कैरियोटाइप और माइक्रोएरे की छुट्टी कर दिया, बट ऑल एग्जाम के लिए क्या करेंगे?
All exam नहीं करना।
बता रही हूँ अभी माइक्रोएरे सबका करना है, सबका इसलिए अल्ट्रासाउंड नॉर्मल हो तो सबका होल एग्जाम करना है।
So coming to the next case. So in this case also there was high risk.
Polydactyl you can be chromosomal as well as monogenic. Divided जैसे transmitter हो सकता है, तो वो नहीं है, बाकी microarray में कुछ नहीं मिला है। ऐसे which can be a part of homogenic syndrome, but ultrasound पूरा normal है, आपने सिर्फ of transmission 21 के लिए किया है, वो exam sequence में नहीं ऑफर
Then coming to next case, so this female also had high risk for trisomy 21 in serum screening. So they had opted for microarray. So till now we have seen that microarray is useful in these cases. So in this case, we identified a small loss of around 264 kb on 7q31.1, and there was only one gene that was included in the deleted segment, that is IMMP2L. So next we will do the literature review. So this particular deletion is reported in normal population, that is DGV. So there are multiple entries in Decipher also. Now there are some case reports where they have shown that deletion of this particular gene is seen in cases of autism. So this report published in 2018, and then this is 2014 research article. And then another research article, this was a meta-analysis. So they have shown that this particular gene deletion is associated with autism. So although it is reported in DGV, this is a database of normal population. But since mild cases of autism may go undetected, they may be treated as normal population. So these type of variations may be present in databases like DGV and may be associated with disorders such as autism. So in these type of cases, we need to do extensive literature review, and then we can counsel the family. So this is the last slide. So in this, they have compared the yield of comparative genomic hybridization in around 7,400 pregnancies. So they have seen that around 5,000 cases in which microarray was normal, karyotype showed abnormal result in 31 cases, that is around 0.6%. So that was a triploidy. Okay. So they had done array comparative genomic hybridization, which does not pick triploidy. So that was missed on microarray but was picked up on karyotyping. Okay. So if we are doing normal microarray, then diploidy can be missed, which will be picked up by karyotype. And in 34 cases, karyotype showed balanced translocation or inversion. Okay. So there are some points that we should remember. Microarray can detect submicroscopic chromosomal gain or losses. So it is now recommended for all cases that are undergoing prenatal diagnosis. The detection rate is 6 to 8% in cases with fetal malformation and 1 to 2% in other cases. Diagnostic rate depends on the type of malformation and the number of system affected. In multiple malformations, the detection rate will be higher. Pre-test and post-test counseling is very essential to explain the uncertainties that are associated with these tests. Thank you.